Join Yvette Walker every Tuesday at 4 o'clock p.m. on KMET ABC News Radio, 1490 AM, FM 98.1, and Internet KMET TV for the Southern California Business Report. The show is dedicated to highlighting successful businesses and the individuals behind them. Yvette interviews the incredible people managing these enterprises that range from awe-inspiring sole proprietors to world-renowned organizations. The Southern California Business Report, Tuesdays at 4 o'clock p.m. Welcome to KMET 1490 AM ABC News Radio and the Southern California Business Report with Yvette Walker, a show dedicated to highlighting successful Southern California businesses and the people behind them.
Welcome and thank you for joining the Southern California Business Report on ABC News and Talks, KMET 1490 AM, 98.1 FM, and KMET TV. I'm Yvette Walker, live blasting our signal from the center of Southern California, serving a population of over 25 million. Get us crystal clear and on demand by downloading the free KMET live streaming app on Google Play or the Apple App Store. A huge shout out to the team as always, Mitch, Bill, and Sean, you know I love you, and to our special advisory committee, Bill Morris of UCI School of Business, Diane Cavallo, and Camila Rubio. Thank you so much. Don't forget to check out the Jay Kaplan Show, also on KMET on Fridays at 3. Today, I have just the distinct privilege to introduce Dr. Andreas Kaiser, Professor and Chief of the Division of Colorectal Surgery at City of Hope, one of the largest cancer research and treatment organizations in the United States, talking about early detection and the latest in less invasive cancer treatments and screening. Dr. Andreas Kaiser is Professor and Chief of the Division of Colorectal Surgery at City of Hope. As colorectal surgeon, Dr. Kaiser has an extensive experience in robotic surgery and every aspect of even the most complex colorectal diseases. He is well-versed in hereditary colorectal cancer, inflammatory bowel disease, functional disorders of the colon and rectum, and benign disorders of the anus. He has become the doctor of choice for challenging cases. Thank you so much for joining us today, Dr. Kaiser.
Yvette, it's such a pleasure to be here. Thank you very much for that.
Well, I'm so happy that you can join us. Please share with us the journey that you have taken to becoming, the head of and the professor at City of Hope in colorectal treatment for cancer. Take us down memory lane. What was it in particular that kind of guided you to this destination that you're at today?
Well, I'm already a little bit older than the average people who I work with. And I started many, many years ago back in Switzerland. That's where I'm from. So English is actually only my sixth language.
Oh, wow.
And I went to medical school initially really with the thought of not doing surgery, but then surgery, I realized, was the thing where you can change people's life. You can really go in there and you do something, you achieve something, and it makes a big difference. And so that was really the entry point. I did my training initially in Switzerland, then did 2 fellowships in the US, one at Harvard Medical School and one at the University of Southern California. And that's ultimately where I stayed as faculty from 2000 to 2019, the end of 2019. I was a professor there, and in 2020, I saw an opportunity at City of Hope, which is really an institution that is not only known at that point, but it's growing and it's expanding. We currently have just recently acquired made a collaboration with Cancer Treatment Centers of America. So we became one of the largest cancer institutions, and that's really a great opportunity. And it's a network where we have extremely smart people thinking about how we can make cancer treatment better and the successes more durable and ultimately to the benefit of the individual patients, but also to society, that we understand what we're actually fighting against.
That is just phenomenal news. And that's actually kind of breaking news. What is it about Cancer Treatment Centers of America? How do you see that, working alongside City of Hope and leveraging all of those amazing resources moving forward?
So far, City of Hope had its main campus in Duarte, a little bit northeast of Los Angeles. And it had a whole community network of, I think it's about more than 35 sites spread throughout the entire Southern California. We're currently building a brand new campus in Orange County, which should become like a second hub. And we ultimately realized that the Cancer Treatment Centers of America are a little bit a similar philosophy as we have, patient-oriented, cancer-centered, and they have three main campuses, one in Phoenix, one in Atlanta, one in Chicago. And so we really sort of overnight spread out and became a national institution. And I think that's, again, making us stronger. We have broader relationships. We can also work with more patients and get results and do research and promote the knowledge about cancer.
Wow, that is so exciting. I mean, talk about a force multiplier, right? I mean, now you are completely national in just tremendous hubs alongside an organization that is also extremely well known for cancer treatment and research. So Dr. Kaiser, let's talk a little bit about your philosophy, okay? Because I know that a lot of people, you know, including myself, sometimes when we think about, you know, visiting a doctor, getting pre-screened, or even giving ourselves the attention that we deserve, you know, sometimes there are barriers and different philosophical ideas about how to move forward. What would you say has been the philosophy for you and the one that you transmit to your patients and those that are listening today about, you know, screening, about caring for yourself and cancer prevention?
I think one of the biggest obstacles that a lot of people have in just dealing with their own health and what needs to be done is really anxiety. Anxiety to find something, anxiety to have to do something, maybe anxiety to all of a sudden become aware of something that you didn't know about yourself. For example, a genetic risk constellation or something like that. And so they sometimes come with established diagnosis and they have anxiety what the treatment could involve and so forth. So the philosophy is really to make them feel comfortable, come to our place, regardless how severe or insignificant a problem might be. And we look at it and we analyze it and we take one step at a time, at a moment, and guide them through the process of figuring out what it is, telling them what the options are, and then try to find a solution. And I think one of the things that sets us apart from many other institutions is that we don't just take like a keyword, for example, stage 4 colon cancer, and say, that's it, we write you off and so forth. But we really say, we look at your situation and we push the envelope. We try to, even out of a more serious condition, try to make out the best and fight for a good outcome.
Right. And I understand that also City of Hope does a lot in terms of research and trying to find new effective therapeutic methods. Are there any clinical trials that you have seen or that you're working on in relation to colorectal cancer?
I mean, there are many trials open currently, mostly for patients who have more advanced disease that has already spread to other organs. And that's obviously a very serious condition because it's an area where maybe surgery doesn't really provide the first tool to intervene, because we can only attack or cut a limited number of targets. So we got to have a specific target. This is what we want to operate, etc. Whereas if somebody has a cancer that has spread to different locations, then the chemotherapy is really what the tool to get the treatment to every site in the body. Now there are different medications, different protocols, etc. And there are lots of trials that are open to sort of fine tune which works better and which works not so well. Now, if we look back many, many years, like 20 years ago, then at that time, the chances for really having a longer survival when you had disease that had spread to different organs was not as good. And since then, there have been many, many new treatments that nobody could even dream about 20 years ago that have really made a tremendous difference in terms of life expectancy, chances to suppress the tumor, chances even to cure tumor. I mean, we cure sometimes patients that have metastatic disease, meaning disease that has spread to other organs, and we can still tame the beast with medications and then sometimes go after it with surgery. Once sort of the tumor has gotten smaller in the different locations, then we go after it and attack it.
And so what is it about the latest technology in cancer treatment and, addressing the various cancers under your scope that you are most excited about?
So I'm obviously a surgeon, so I look at tools and approaches. And when you look again back maybe 30 years, then there was only one way to do surgery, and that is making a very large incision from the sifo, or the lower end of the chest bone, down to the pubic bone. And you put both of your hands in there and you go and find the tumor and cut it out. And that's still not a bad surgery, but it obviously is a very large incision. It creates what we call a surgical trauma. So yes, we do the treatment because we want to fix something, but on the other hand, our intervention also creates a little bit of a trauma. And so that trauma is certainly not insignificant. And it's associated with pain, it's associated with formation of scar tissue inside. It's associated with the patients forming hernias along those incisions. So I think we all try to minimize that trauma. And so maybe in the early 1990s, that's where laparoscopy came up. Laparoscopy uses a different approach where you use not just one big incision, but you use many small incisions, introduce instruments through those little incisions and do a lot of the work inside. And that minimizes the surgical trauma such that you essentially can do most of the freeing up inside, and then at some point you've got to make an incision to get the actual tumor out. But that's substantially smaller than when you do it with a conventional. The continuation of the laparoscopic surgery is the robotic surgery. And robotic surgery sounds futuristic, and it is to some degree, but it's not in a way that you push a button and the robot knows exactly what it needs to do, and I put my legs up and drink a pina colada or so. That's not how it works. So the robot is essentially just a high-tech machine that translates the movements that the surgeon makes. Now, the surgeon doesn't sit right next to the patient, but the surgeon sits like in a cockpit. We call it the console. And in the console, he has like a 3D vision, and he has little handles where he can really make the very fine movements of the robot. And the robot takes those movements and translates it into the movement. So the robot is the tool that holds those instruments that go through those small incisions into the inside of the patient. And so it makes, I see the instruments through the camera that is in there, 3D, with very high precision. And I can do all the nice dissection steps from my cockpit, and it happens at the bedside. So then I do essentially most of the surgery inside. I even do the reconnection of the bowels inside. So I suture them together. And ultimately, yes, I got to make an incision to retrieve the piece of the tissue that we want to remove from the patient. So I've got to make some more an incision, but take whatever, that's 10 minutes where that is opened up and then taken out and closed again. And so those surgeries are typically taking a little bit longer than if we make the big incision. But on the other hand, we create less of a trauma. We have a direct view with almost a microscopic view of the surgical field. We can come very close with the camera. And that way we can do a very precise dissection, much less trauma. And the result of that is that most patients' intestines don't feel traumatized and they wake up faster. So as I said before, when we do the conventional large incision, that means that the bowels are a little bit offended, they don't like us in there, and they shut down. Whereas if we do it robotically, they don't even stop working. We see the bowels moving while we do the work inside. You see the contractions, etc. So they never shut totally down. And again, that's associated with a typically much faster recovery after such a surgery.
Wow. Okay. That is remarkable. And I can almost visualize it as you're describing it. It's so detailed. Thank you for that. So please, Dr. Kaiser, share with us, what are some of the things that, as potential patients, we need to look out for, if we're thinking, gosh, I feel like there's some digestive issues. I feel like there's something going on. When and what should prompt us to go and seek the advice of yourself or a doctor like you?
So I think it's really, really important to just put in your brain that we are all at risk for colorectal cancer. And that's something we'd like to say every month of the year, but certainly in March, we call the Colorectal Cancer Awareness Month. We put a specific emphasis in promoting awareness of the fact that we all are at risk. So 4 to 5% of Americans will get colorectal cancer or are at risk to get colorectal cancer. That's a substantial number. Now, yes. The good news about colorectal cancer is it's not popping in overnight. It's not just yesterday there wasn't and tomorrow there is, but it's a process that on an average person may take up to 10 years. So you have a normal colon, then you form what we call a precursor lesion. So it's not cancer yet, but if we leave it there, it may turn into cancer. And that's typically what we call a polyp. So the polyp is a little growth in the wall of or in the lining of the colon or the rectum. And if we leave it, it grows bigger. And if we remove that polyp before it grows roots into the wall, then we can actually reduce the cancer risk by probably 85–90%. We can't 100% eliminate it, but we can dramatically reduce it. And so that's our great opportunity to intervene and reduce the incidence of cancer. So again, knowing about that fact, not ignoring that we're at risk is absolutely important. Now, the solution to that is that we engage in screening. And screening means that you do a test in somebody who does not have any symptoms. So you want to look for a specific disease or a specific treat or something like that. That's called screening in somebody who does not display any symptoms. There is another thing if you have symptoms. So if you, for example, have bleeding or change in bowel habits or some bloating or some pain or so that develops, none of those symptoms are specifically telling you have cancer. However, if there is a change, then we don't do really screening, but we need to look for symptoms. What causes those symptoms? And that means that we may have to do a colonoscopy or some other test that seems to be appropriate for that specific situation. So again, the message here, Yvette, is that yes, we have all a risk, but if we don't go into denial and we keep looking early enough, then we have a good chance to actually prevent this.
Right. And so that's why I value all of these opportunities so much. I personally have cancer in my background on both sides of the family. And because of that, I was prompted to start doing the breast ones, the mammographies much sooner. So I had my first one just after my 30th birthday, just to have a baseline. And from then on, I get them on a regular basis. Every October, I'm there. Even during the pandemic, I was in there, and it's actually super clean, super streamlined, very efficient, in and out, with all of my blood labs and my mammography completed, and with the sense of knowing that I'm healthy, and that if anything starts to develop, that I'm catching it early enough to where it can be treated, and it's not something like deferred maintenance where it just is so overwhelming that you don't even know where to begin, right? And I guess that's the sense that is important to share with our audiences, the importance of being on top of it and doing those screening processes so that we know how our bodies are, working along, just the way we care for our cars, right? That's my favorite analogy. We care for our cars. We change the brakes, we change the tires, always filling it up with gas and doing the oil changes and the filter changes. Anytime we sense something wrong with our car, we immediately take it into the shop. So I would love for all of us to adopt that same mindset for our own bodies, for our own beings.
Yeah, you bring up a very, very important point, and you mentioned that you did all those things even during the pandemic. And I think one of the findings that we really became very quickly aware of is that people cut short the need to do cancer screening in that time. And sometimes it was not even their fault. Sometimes the gastroenterologist said, well, we're closed shop. We don't do any tests. The risk of us getting COVID and so forth is too high. And now we start to see the wave of patients who come out of that and maybe have experienced a delay in diagnosing a cancer or diagnosing even a precancerous thing that we just need to take a lot more work to get rid of. So the other thing that you mentioned is that you look for specific risks because you have a family. So everybody is at risk for colorectal cancer, but there are people who are more at risk. So when we look at the risk profile of a patient, of an individual, I shouldn't call it even a patient, of an individual, then we have average risk people. And those are people who have no family history, no specific known genetic risks or so. They don't have any underlying diseases that are associated with cancer development. And even those people have the risk of developing colorectal cancer. Then there are high risk situations or increased risk situations. So if you have like certain family members who have underlying disease, but you don't necessarily know of a genetic mutation or so. And then there are really the high risk situations where we have cancer syndromes where we even know a gene that is associated with it, and we know with what frequency that gene is passed on from one generation to the next. In some of those families, we know that every second family member has a cancer or a risk for cancer, where we may have to do a very significant surgery to eliminate the colon before it turns into a cancer. So we can, in those patients, remove the entire colon and rectum and create a new anatomy that is not exactly normal, but that works very closely to normal. So very important. Then there are other diseases like inflammatory bowel disease. So somebody who has like a long-standing history of ulcerative colitis or Crohn's disease or so, those are not cancer diseases from the beginning, but as they sort of create this chronic inflammation throughout the entire intestine, they really trigger the growth of a cancer over many years. So those are high-risk situations, and those are situations where we're not waiting for the 45. The 45 is the new 50, where everybody should start getting a colonoscopy. But in people who have those high-risk constellations, they may have to start looking substantially earlier.
So those that are experiencing IBS or irritable bowel syndrome and some of the other more chronic inflammatory diseases should consider doing screening at an earlier age. Is that what you're saying, Dr. Kaiser?
Not irritable bowel syndrome, but inflammatory bowel syndrome.
Inflammatory bowel
So
syndrome.
irritable bowel syndrome is actually, the colon is totally healthy. The hardware is okay, but the software runs a little crazy. Whereas inflammatory bowel disease, you look inside and the lining is totally inflamed. It looks angry, it looks red, it bleeds, and so forth. That's a different disease. The irritable syndrome, bowel syndrome, that's a no risk.
Got it.
Inflammatory bowel syndrome is a very high risk.
Okay, so thank you for that, Dr. Kaiser. For those listening, I'm Yvette Walker on Southern California Business Report on ABC News and Talks, KMET 1490 AM, 98.1 FM, and KMET TV, talking to Dr. Andreas Kaiser, Professor and Chief of the Division of Colorectal Surgery at City of Hope, one of the largest cancer research and treatment organizations in the United States, talking about early detection and the latest in less invasive cancer treatments and screenings when we return.
The University of Laverne is rated first in California for alumni satisfaction. Learn more about accelerated programs offered online and on campus in Laverne, Irvine, Ontario, Burbank, or College of the Canyons. Visit go.laverne.edu. The University of Laverne. go.laverne.edu.
Cal State San Bernardino is home to the only school of entrepreneurship in California. With globally ranked degree programs, you can start your journey today to become a successful entrepreneur. Learn more and connect at entre.csusb.edu.
City of Hope is driven to making a difference in the lives of people with cancer and diabetes. We accomplish this by conducting innovative research and providing outstanding care. If you or a loved one has received a cancer diagnosis, go to cityofhope.org to learn more about how our innovative approach could change your outcome.
Every 2 seconds, someone needs a blood transfusion. Be on the giving side. Livestream Blood Bank supports patients in 80 Southern California hospitals. Call 1-800-TRY-GIVING for more information and to set an appointment.
Ontario International Airport is onto a better way to fly with over 65 daily nonstop flights to more than 20 major destinations and the easiest airport experience in Southern California. Visit flyonto.com/Ontario to learn more about Ontario International Airport today.
Hi, I'm San Bernardino County Sheriff Shannon Dykes. If you're looking to start an exciting career in law enforcement and make a difference in your community, we are hiring dispatchers, nurses, deputies, laterals, and many more. For a complete list of our jobs and more information, visit sheriffsjobs.com.
Welcome back. California Business. For those listening, I'm Yvette Walker on Southern California Business Report on ABC News and Talks, KMET 1490 AM, 98.1 FM, and KMET TV, talking to Dr. Andreas Kaiser, Professor and Chief of the Division of Colorectal Surgery at City of Hope, one of the largest cancer research and treatment organizations in the United States, talking about early detection and the latest in less invasive cancer treatments and screening. Before the break, Dr. Andreas Kaiser, we were talking about, some of the groups that should consider pre-screening, which ultimately turns out it should be all of us at some point, some sooner than others. But let's start stepping into some of the treatment options that you have found to be most successful for your patients.
I will get to that question in just a second. I'd just like to quickly go back to the screening or pre-screening. So again, I think when we look at how frequently cancer shows up in or is diagnosed in the people throughout the country, then we see overall our efforts with screening are really paying off. So we see in many age groups, we see that there has been a decrease in the last 30 years or 20 years for sure, that it has gotten slightly better. And that's true for what we call the incidence, so the number of new diagnosed cases per year. And it's also gone down in regards to overall, the chances to die from a colorectal cancer has gone down. But there are exceptions, and the really scary exception is young people. So there are some young people that we are obviously aware of, and that's, for example, Chadwick Boseman or so, who are very, who was very private about his diagnosis and ultimately succumbed to that disease. But we see in a cancer center like City of Hope, we see young patients almost every day. And so our efforts need to focus a little bit on, again, starting the regular screening in time, but knowing the family history, looking, asking around, hey, did you have polyps or cancer or whatever? Try to understand who really has a risk in your family, because it could mean that you have a risk. So have an open conversation about those potential impacts that could affect you directly, or your kids or so forth. So ask your spouse what their history is and so forth. And if there are any symptoms, then we don't want to wait until somebody is 45. Then we want to really go and do a diagnosis. It's really shocking if a patient, today I saw a patient and she had rectal bleeding, and she was told twice by some people, some physicians, oh, it's just a hemorrhoid or a fissure or something like that. And it turned out it was a rectal cancer. And I think that's really where, if somebody has symptoms, we gotta go and check. We can't just make assumption. It's okay to make an assumption. Say, okay, maybe it's your hemorrhoids. We check for 2 weeks or so. But then if it's not, then we go and maybe do a colonoscopy, even if somebody is very young.
Right. And so just to clarify, you spoke about finding polyps and removing those at an early stage. Can you please expand on how those polyps are found and the process to remove them?
So again, there are different tools available to look for problems in the colon. The gold standard is a colonoscopy. That is, you need to take laxative to clean out all the poop, and then you go in with a long tube that has a camera at its end, and it has also some working channels where we can insert little instruments, and we can take biopsies, or we can remove polyps, etc. And so we go to we insert it and advance it all the way to the beginning of the colon, where the small bowel enters the large intestine. And then we examine the surface. And when we see something, then obviously we have the opportunity to immediately take care of it. So if we see a polyp, we remove it. Unless it's super large, then it may not happen. So that's the gold standard. There are other tests, like stool-based tests. There's, for example, Cologuard or fecal occult blood tests, where we just look, is there anything secreted in the stool that could indicate that there is a cancer? But you've got to realize that those are very, very unspecific. So if we have like a positive test, the chance that actually there is a true cancer is probably 1 in 1,000. So it's not very likely, but it means that if you have one of those tests, then you need to go and do a colonoscopy. The thing that people are most, I should say, maybe scared or annoyed off by is to clean out the colon. And I can tell you, I did it a couple of times myself. So I know what we're talking about. It's not that I haven't done a cleansing myself and say, well, you should do it. I did it myself. And it's a little bit annoying, that's true. It's very important to do it well, because that way you can really see the whole colon wall very nicely and have ultimately a chance to say, yes, everything is clean, you're good for the next 10 years, or we saw this or that problem, we took care of it, or we diagnosed truly a cancer. So that's really our gold standard.
So are there specific groups that should consider pre-screening at an earlier time versus, the general public, or what are the age indications that you would recommend for those that are looking to become pre-screened?
Well, I think there, again, the average, the new 50 is not 50 anymore, but it's 45. And then if you have certain risk factors, so for example, African-American people, they are at higher risk, particularly young men, they're at higher risk. And that's the group where we saw still an increase in the number of new cases per year. So those are certainly people where we encourage to maybe start even 5 years before that. Now, if you have a family history, if you have a first degree family member who was diagnosed at a younger age, then you should probably start colonoscopy, whatever, 10, 15 years before that age. Sometimes a young age indicates that there is a genetic mutation. So one way to look at your own risk, so let's say your mother or so had, or your mother or father had a colon cancer at a younger age, then you can try and look in that specific individual and do an analysis of the genes and see, are those genes that have a potential to be passed on from generation to generation, or is that a genetic, whatever, error that happened just on the spot and is not going to be passed on through multiple generations. So if you can identify the gene mutation in your parents, and then you look in yourself and you have the same mutation, then you're at super high risk. And then you need to go and start screening much earlier, at 20, 25, something like that. In some cases, even in the later teens. If, on the other hand, you can identify the gene in your parents, but you don't have it yourself, then you can say, okay, fine, that's great. I'm not at risk. I can wait until 45, and then I start my just regular screening as everybody else. And so genetics really play an increasing role in getting the fingerprint of cancers. So identifying what kind of cancers are they? What's their risk of being passed on to the next generation? What's their profile of responding to this or that treatment? So that's the other area. So surgery has made tremendous progress in the last 20 years, but certainly molecular understanding of how cancer actually happens and how we can interfere with the cancer growth and maybe stop that growth, that has been the other area where really there has been enormous growth.
Right. So in addition to the pre-screening opportunities to ensure that, we're keeping track of it and we're making sure that we're not developing any cancerous lesions or polyps or anything of that nature, are there preventative measures that we can take to decrease our chances of developing colon cancer?
So there are obviously the risks that you can't affect. You can't choose your parents so far, right? But on the other hand, you can choose a little bit the lifestyle. So there are certain things that we know are associated with increased risk. So it is maybe a sedentary lifestyle, maybe certain types of foods that we consume. So if we look at larger populations, then countries, for example, that have a higher consumption of red meat are showing a higher chance of getting colorectal cancer on average. That doesn't mean that if you eat a steak today, then tomorrow you will have a cancer. It's not like that, but just on average, just epidemiologically, it's been associated with that. There is oftentimes maybe a bit of a lack of fiber content. So it's certainly for many, many reasons, not just for colorectal cancer, good thing to not eat too much, keep your weight in a reasonable fashion. I'm not saying that everybody needs to be like super skinny and so forth. I'm not super skinny myself, but you need to try to have maybe not the excessive weight, because that really increases your risk significantly. We don't know exactly how it happens, but we see that that's certainly a factor. Then there are other components like smoking and alcohol consumption. There are other things that you can't really, they're not necessarily something you can dictate, but for example, if you had radiation treatment for any other condition, maybe you had a cancer before, that increases the risk. And so if you had one tumor, please make sure that you don't get another one by just looking frequently enough and dealing with something before it turns into a cancer.
Right. And so there are all of these tools at your disposal and all of the expertise, including, robotic surgery and all these different treatment options. So Dr. Kaiser, can you walk us through, let's say a patient that comes in and you identify a cancer? Walk us through the process of what the treatment would look like for that patient.
So broadly saying, we got to start with finding out what is the stage of this cancer. So we know certainly that if we have a very early stage, then we need to maybe use less tools to fix that. If we have a very advanced stage, then we need to really use all the tools that we have at our disposal. So the staging is really important. And that means that once, for example, you had some symptoms, you had some bleeding, and now the gastroenterologist or a colorectal surgeon has done a colonoscopy and identified a cancer. So then we, on one hand, got to wait for the pathology to come back, and the pathologist should already tell us a little bit about the genetic, whatever, basic appearance. It's not a total molecular analysis, but it gives us a little bit of a hint about what we can expect. And then we got to look with imaging, where else is the tumor? Has it stayed just a local problem in that area where it grew? Or has it already started to spread? And the first spread that a colorectal cancer would do is it goes into the lymph nodes. The lymph nodes are almost like the first filter station. So the cancer grows into the wall. I said before that it grows roots into the wall. It starts to grow deeper into the wall, and ultimately in the wall, there are blood vessels, there are lymph vessels. And so the cancer cells can intrude those structures and ultimately travel with the lymph, travel with the blood to other sites. And again, the lymph vessels go to the lymph nodes, and then the blood vessels would go to other organs, such as the liver or the lung or anywhere else in the body. So that's what we try to capture with what we call the staging. So we do imaging, x-rays, CT scans, and so forth to define where is it? What are our targets? And then we sit together, and again, at an institution like ours, like City of Hope, we have 2 tumor board meetings for just colorectal cancer twice per week. So different specialists come together and discuss every single individual case. And we discuss, should we start with surgery? Should we start with chemotherapy? Should we start with radiation? Or we also see the follow-up. We've talked about a patient before, and now we've done certain treatments, and now we see how the progress is, and we can again decide as a collaborative group, this is, in our opinion, the best way to proceed from here. So very often surgery plays a role. Surgery is in many ways the tool that really can cut the tumor out and put it in a bucket, and then it's gone. And again, that's the reason why I chose surgery as my own profession, because you can really achieve something visible. But on the other hand, we also realize that certain constellations increase the risk that, again, the cancer cells have already departed from that site. And that's where then patients may need additional treatments such as chemotherapy or radiation therapy or something like that. And so, for example, if we look at the rectum is the last part of the large intestine. So we have the colon, which encompasses the majority of the large intestine, and the last part, the last maybe 15 centimeters or 6 inches of that are called the rectum. And the rectum is embedded in the pelvis, and it's close to the bladder and the prostate in a man, or to the female structure, uterus and vagina in the female. So it's all very close, and we don't have a lot of extra tissue that we can just take away as a safety buffer zone. So in the pelvis, we oftentimes add radiation to help us sterilize the field. Now, 20 years ago, the sequence would have been you get the diagnosis, then you do the surgery, and then afterwards you add chemotherapy and radiation therapy. And nowadays, we've actually reversed that order for rectal cancer. So we pre-treat that field with radiation and chemotherapy and sort of try to sterilize the area, and also try to take care of cancer cells that already departed and are on their way to travel to other organs. And then we take a break and reassess, and would then be prepared to do the surgery that we wanted to do. Now, the amazing thing of that approach is that in up to 30% of those rectal cancers, the cancer totally vanishes. It's just not visible anymore. We can see maybe a scar. That's it. It's totally disappeared. And that has created a very interesting problem, a good problem to have, where we got to ask, should we still do that surgery, or should we just keep an eye on the area? And that's what we actually do in those patients where we really can't see anything. We just watch them. We monitor the area frequently. And very often we get by. We don't need to do the surgery that we initially were set out to do.
And so what would you say is the most positive outcome that you see in patients that are, faithful in their screening and staying up to date on their colonoscopy versus a patient that comes in that already has, let's say, symptoms?
Well, again, the former group hopefully never has a cancer to begin with, because you go in there and you chip away the precancerous lesions. And again, you can't 100% rule out that the cancer will develop, but you can reduce the risk overall very significantly. And the other thing would be that if you have a cancer, if a cancer forms, then hopefully you detect it at a stage where it's still much earlier and has an extremely good chance to get cured. Again, our hope is that we can cure cancer. And I think the good news about colorectal cancer, in contrast to many other cancers, is that we have, with our combined treatments, overall a very good chance to cure it. Certainly, in the very early stages, it's almost a guaranteed cure. In the intermediate stages, I think we have excellent results. And even in the ones where the tumor has spread to other organs, we should never just say, well, that's it. We should really say, let's see what we can do. And that's where we have patients who travel from the whole country. They went to very known, reputed institutions at the East Coast or in Texas or whatever, and they come to City of Hope and look around and see what we can do. And then oftentimes we can actually do something for them. So I think that's what we try to achieve.
Well, that is...
Be optimistic, not take away hope from the patients.
That's an absolutely inspiring testimony. Thank you for sharing that. And with that said, can you please talk about the importance of donating blood and platelets and how that translates into the treatment of those patients that are battling cancer?
So obviously the immediate question is, does somebody need blood for a major surgery? And yes, sometimes we do need blood for major surgeries, but the truth of the matter is and I happen to be on the transfusion committee of City of Hope. The majority of our need for transfusion or blood products is actually more from the patients who do have non-colorectal cancers like leukemia. City of Hope is the nation's largest bone marrow transplant place. So they have a lot of patients with leukemia who can form blood, can form white blood cell counts, can form platelets and so forth. And for those, it's enormously important. But then for the surgical patients, yes, we sometimes do very, very big surgeries that unquestionably have a risk of getting having some need for blood. And for those, it's very important. And then there are some patients who suppress their bone marrows by the chemotherapy or the radiation therapy. So those are situations where it's important to have those products available. And again, as a result of the COVID pandemic, we noticed that people don't want to donate as much anymore. What we have started doing is when we have a patient who needs a major operation, we ask directly their family members who are often sitting in the room, are you willing to donate? It's about your family member. Because there are certain blood groups where it's just, we gotta have enough blood, and the families are willing to do that.
Wonderful. Thank you so much for sharing that. Thank you for expressing your expertise and giving us all a very important guideline on how to look at this and prevent it in the future. So for everyone that's listening, look for us on Facebook, YouTube, LinkedIn, and Instagram. Check us out on scbrtalk.com. And don't forget to download the free live streaming app on Google Play or the Apple App Store. Don't miss my interview with Dr. John Bunkers, a Southern California native who attended South Hills High School, attended Cal Poly University Pomona, and graduated from the University of the Pacific School of Dentistry in 1978 with a doctoral in dental surgery. In his career, John has served as an associate professor of restorative dentistry at UCLA School of Dentistry from 1978 to 1981, was the founder and managing partner of the San Dimas Dental Group from 1980 to 2020, which included a 6-doctor multi-specialist practice, was the vice president of the American Academy of Clear Aligners from 2017 to 2020, and was recognized as a Diamond Plus dentist and 1% world provider of Invisalign dentistry in 2021. Today, John is the administrator and moderator for the AIR Institute, a group that provides cutting-edge technology of the next generation of dentistry, including sleep dentistry, treatment of obstructive sleep apnea, and laser rejuvenation. In addition to his dedication to providing the latest in dentistry, he is part of a successful business group of investors known as the Colonies Partners, who together purchased 400 acres of mixed-use land in Upland, California from 1996 to present. John has 2 beautiful daughters and a lovely granddaughter named Lily. Next week, we will have Manuel Zavala, the founder and CEO of Student Hires, an educational company focused on creating and connecting students with valuable job opportunities. Manuel came up with the concept of his student hires while working towards his bachelor's degree at the University of California, Riverside. During his time at UCR, Manuel balanced the life of a struggling college student with the life of a high school computer science teacher. With the help of many mentors, he was able to return to his hometown of San Bernardino to teach on a part-time basis while attending college. After gaining 4 years of high school teaching experience, he made the leap to focus solely on student hires in October of 2021. Now, Student Hires has been focused on collaborating with K-12 schools and districts, colleges and universities, as well as community employers to create valuable job opportunities for local college and university students. Don't miss it, everyone. We will see you next week.
Join Yvette Walker every Tuesday at 4 o'clock p.m. on KMET ABC News Radio, 1490 AM, FM 98.1, and Internet KMET TV for the Southern California Business Report. The show is dedicated to highlighting successful businesses and the individuals behind them. Yvette interviews the incredible people managing these enterprises that range from awe-inspiring sole proprietors to world-renowned organizations. The Southern California Business Report, Tuesdays at 4 o'clock p.m.